Good evening, everyone, and thank you for joining me tonight for my PowerPoint presentation on managing PCOS naturally. So if you have any questions at all during this presentation, please leave them in the comment box and I will get to them at the end. Otherwise, stay tuned and we're going to jump right in. So this is just a disclaimer that I'm not giving any medical advice currently. If you do have any medical questions, please consult with your doctor, or if you're interested in becoming a patient, you can go ahead and sign up with me. Otherwise, please consult with somebody before starting any type of new treatment. And just a little information for those of you who don't know who I am. I graduated from Western Michigan University. I then went to chiropractic school in Port Orange, Florida, and I recently have become board certified chiropractic internist. I am still awaiting to take my nutrition boards, and I currently practice functional medicine in Berthoud, Colorado at Gateway Natural Medicine. So we're here to talk about polycystic ovarian syndrome. It's estimated that 5 million women in the US suffer from PCOS, and other resources suggest that number is even higher, upwards of almost 10 million women. The majority of these women that are diagnosed are typically in their 20s or 30s, but PCOS may affect girls as young as 11 who haven't even had their first period. So these are some of the more common questions that I'm faced with. My doctor says the only way to manage my condition is with birth control. Is this true? Will I be able to have babies in the future? What is going to happen to me? So there's some very common things that I'm used to hearing, and we're going to kind of dive into all of these things. Before we get too far in, I just want to go over what some of the diagnostic criteria for PCOS is. The most recent diagnostic criteria that we have is this last section over here on the right, androgen excess and PCOS Society. This was updated in 2009. They say that there needs to be 2 of the 3 present, with A being present plus either B or C. The Rotterdam criteria is some of the more common ones that we see, and this requires you to have 2 of the 3. And then the National Institute of Health, you can see that one is pretty outdated from 1990. They're saying that you should have both of the findings marked below. So it's interesting when we look at this criteria that it's not necessary for a woman to actually have cystic ovaries, but to kind of fulfill some of these different symptoms here. So we're going to dig into some of the science behind what's going on with PCOS, because I think a big part of this disorder is understanding what exactly is happening. So I'm going to kind of go through and explain what some of these hormones that you may have heard of before, what they do and what they mean to the body, and how they may be affected in PCOS. So what is a hormone? A hormone is a chemical that is released by a cell, gland, or an organ in one part of the body that sends out messages that affect cells in other parts of the organism. So we can think of this as somewhat of a communication system. I'm going to dive a little bit deeper from the ones that I've mentioned here, but basically the brain talks to the gonads, or our sex organs, via something called FSH and LH. And then these messages from the gonads are what talk to the cells. So this is kind of the basis of how a hormone works. So the normal menstrual cycle has lots of different hormones that we're going to talk about here. I think this picture depicts pretty accurately what's happening during the menstrual cycle. So I'm going to talk about a few different areas of the brain, the first one in particular being the pituitary gland. So the pituitary gland releases 2 hormones called FSH and LH. FSH is follicle stimulating hormone, and LH is luteinizing hormone. So FSH is responsible for the maturation of the egg that is inside the follicle during the first phase of the menstrual cycle. Basically, what this does is it stimulates estrogen levels to increase. Once they get high enough, that stimulates the release of LH. The release of LH, again, is triggered by a peak in estrogen levels before ovulation, and luteinizing hormone is responsible for initiating ovulation, or the release of the fully developed egg. So to kind of explain that a little bit further, let me go to the next slide here. In the normal menstrual cycle, after ovulation occurs, the eggless follicle is transformed into what's called the corpus luteum. This organ tends to secrete progesterone and estrogen, and this is what would eventually help to establish a fertilized egg in the uterine lining. If fertilization does not occur, the corpus luteum continues to secrete some of these hormones and then eventually kind of starts to decrease in size and eventually disappears. And then this whole process begins all over again. So this is a great picture that really depicts how complex the menstrual cycle is in us females. So if we look at the top box, we're looking at the development of the follicle. So looking at this picture, if you look to the far left, there, day 0 or day 1 marks the beginning of menses, or the beginning of when you first see blood during the period. If we follow that all the way up to the top, we can see that the follicle is at its smallest at that point. As we transition through the follicular phase, we see that follicles start to grow. Once we hit ovulation, we can see that that egg is released from that follicle. Now, before we jump into the luteal phase, let me explain what else is happening during the follicular phase. We're also seeing this increase in estrogen, and you can see that little yellow line slowly increasing in the beginning of the month. Once it hits a peak, that's when we see that peak in luteinizing hormone as well as follicle stimulating hormone, and you can also see that that's when ovulation is occurring. After ovulation occurs, those two hormones drop, as does estradiol or estrogen, and we start to see an increase in progesterone. Now, this is happening because if we were to become pregnant, that increase in progesterone would help to support the development of the placenta as well as the growth of the baby. However, since we don't become pregnant with every period we have, there are times that the progesterone will eventually start to drop. Once progesterone drops low, that's when menses occurs. And you can see the shedding of that uterine lining is happening when the hormones are at their lowest. So if we look at this last box that shows the uterine cycle, you can see the kind of dotty, the red and purple dots, that is the uterine lining being shed. And you can see as it goes from the top of the box kind of lower down, that's showing the thickness of the uterine lining. So that is what we shed every month. That the bleeding that we see comes from the uterine lining being shed, and that's why when you become pregnant, you're no longer using that because your body is utilizing the lining to help support the baby. So this is just kind of an overview of how the normal female cycle works, and I think it's really important to understand how this works when we're talking about abnormalities of the cycle. So let's talk about folliculogenesis, or the development of the follicle. Women begin puberty with 400,000 follicles. That is so many. Multiple follicles develop at once, and by day 8 of the menstrual cycle, remember day 1 is the first day of bleeding, by day 8, the body is able to kind of recognize which follicle is the strongest, and what it does is starts to promote the growth of that follicle. It promotes the growth of one follicle so that that follicle can eventually release the egg at ovulation. However, in PCOS, the ovary isn't receiving the proper signals or the proper things from the brain to produce the hormones. So what ends up happening is the ovary isn't really sensing that it should pick the strongest one, and they all just continue to develop, and this is where these cysts come from. And one of the more common things that I tend to hear is, what effect does birth control have on the female cycle? And the reason I think this is important to talk about is because this seems to be one of the most commonly prescribed medications for PCOS. So if we're looking at this picture here, the green represents estrogen and the red represents progesterone. I apologize, this picture is a little bit on the fuzzy side. So you can see throughout the month, we still have this little bit of waves of this up and down pattern of progesterone and estrogen, but we're not seeing it to the point that we saw on those previous pictures where there's that obvious surge of estrogen or there's that obvious surge of progesterone. So what's happening is the birth control, whether it be the pill, ring, or implants, it stops the FSH and L8 surge from the pituitary gland. And it does this to prevent an estrogen rise and thus kind of not allowing ovulation to occur. With ovulation not occurring, we're not seeing that increased progesterone production from the ovary, from that empty follicle. So that's kind of why these hormones are somewhat stagnant throughout the month. We're not seeing that up and down pattern that we were seeing with when women are not on birth control. So just to kind of show you what that picture looks like, again, I'm going to back up here. And you can see here that estrogen and progesterone have that huge surge and that dip, and then that surge of progesterone and again the dip. So here's what we're seeing hormones look like on birth control. Hormonal testing. And I know this picture can be somewhat overwhelming, so I'm going to dive into it a little bit deeper here in a few minutes, but just to kind of go over hormone testing, you should be getting your hormones and their metabolites tested. And the reason being is the metabolites help us to see how well your body is processing the hormones. So the metabolite is kind of a breakdown of the hormones, if you will. Typically in traditional medicine, we may only see a few of these markers. Sometimes I don't see all of them. It kind of just depends on where the labs are coming from. Another important thing to take from this is hormone testing can vary a lot throughout the month. As you saw, our levels of our estrogen and progesterone at some points of the month can be super high, and in other parts of the month can be really low. So it's really important for a female to know where she's at in her cycle. However, I know with PCOS that there's a lot of irregularities in the periods, which makes it difficult for the female to kind of understand where she may be at in her cycle. At that time, it does become more challenging to kind of determine what those levels are. But if the female is still having her cycle consistently, we would like to try and kind of balance the hormone testing off of that. So just to talk a little bit about how receptors work, because I'm going to talk about a lot of hormones attaching to different cells, I'm going to give a little bit of an overview here of what's going on. So all hormones need a receptor that works like a lock and key mechanism. So we've all had that key where you stick it in the lock and it fits, but it won't open the door. And then you also have your key that fits in the lock and also opens the door. Well, just like the keys in the lock kind of work, hormones and cell receptors can work the same way. So these receptors may be able to recognize a hormone, but just because the hormone attaches to it doesn't necessarily mean that it has an action. We want the proper hormones attaching to the proper receptor sites. And the slippery slope of hormone replacement therapy can kind of look like this. If we're looking at this picture on the left here, this is us looking at a cell. The purple box represents a hormone receptor and the blue box represents the hormone itself. So when we're seeing little hormones available to the body, the cell will start to push more receptors to the surface of the cell because it's kind of telling the body, hey, we need more of this hormone. I've got the receptors out here. Please give me more hormone. What ends up happening with that, the body tries to put the hormone on the receptors and it can try to correct itself. However, when there's too much hormone present, the opposite is happening and the receptors will actually move inward into the cell. So if we have a lot of hormones coming in, again, from hormone replacement therapy, and the body is kind of not really able to determine how much it needs, or it thinks it's getting too much, it'll start pulling these receptors into the cell, which means all of a sudden we have a lot of hormones floating around in the body that aren't really attaching to the receptor sites and not having an action. So this is why it's really important to focus on making sure that you're coming on and off hormones in somewhat of a titrated manner. And we're going to talk more about everything than just hormones tonight. So testing the hormones isn't enough. We can have other issues, enterohepatic recirculation. That could be due to the liver not functioning as well as it should be. There may be poor clearance of the hormones. And again, we could see this by looking at the metabolites of the hormones. Poor receptor sensitivity. This may be due to too many hormones being introduced to the body at once. So there's a lot of different things to consider when we're evaluating a hormonal disorder, especially PCOS. And this is why following protocols is not typically recommended in my area of practice. And it's because each patient is so much different from each other. And we're going to get into that here in just a minute as well. So now I'm going to talk to you a little bit about how the hormones actually work in your body. Estrogen. So estrogen is the primary female sex hormone, and just so I can start from this part, all hormones come from cholesterol. So you'll see that pop up on a few slides. Cholesterol is the building block of all of our sex hormones. So it's really important that we maintain healthy and appropriate cholesterol levels, as well as considering the hormones when we're talking about some sort of dysfunction here. So there's 3 different types of hormones that we have as females. We have E1 or estrone. This is the hormone that's dominant in menopause. We have estradiol or E2. This is the one that's dominant during years of menstruation. This is the one that you'll probably see on a lot of slides that I'm talking about, and the estrogen that we'll be focusing on the most tonight. And we also have estriol or E3, and this is dominant during pregnancy. So all of these different levels of estrogen kind of vary throughout our lifetime. So there are some negative effects of estrogen. It can increase body fat. It can cause depression and headaches. It can cause a lot of clotting with the period. So a lot of women will describe having these big, thick clots or mucousy clots. We'll also see loss of zinc and retention of copper. We may see increased risk of breast and prostate cancer, prostate in men, of course. This can impair blood sugar control. And as you can see, some of these symptoms may kind of line up with some of the PCOS symptoms. And that's why it's important to test for all of these hormones, not just testosterone. But as there are negative effects of estrogen, we do have a lot of positive effects that come from estrogen. It's neuroprotective and also cardioprotective. It helps to support dopamine and serotonin production in the body. These are two neurotransmitters that give us feelings of happiness, feelings of joy. It helps to give us motivation. Estrogen can also influence sexual function and also promote lubrication for sexual activity. This is why sometimes as women start to transition through menopause, they may start to notice things like vaginal dryness and decreased libido, and that's typically due to their estrogen levels dropping too quickly. So what do we actually need estrogen for? We need it for all sorts of different things. We need it for brain and liver function. Again, we need it for vaginal lubrication. It helps to support the thickness of the vaginal wall. It can help to increase HDLs, which are our good cholesterols, and help to decrease LDLs, which are considered more of our bad cholesterols. And as you can see, there's a lot of other things that estrogen can play a role in our body. Signs of estrogen dominance. One of the most common things I see in practice outside of the PCOS. Some of the common complaints I hear are women that have endometriosis. It's a very estrogen dominant disease, having fibroids, having a lot of PMS type symptoms, having lots of clots, having breast tenderness during the period, lots of symptoms that can be associated with estrogen dominance. Estrogen can also block thyroid function if there's too much of it. So if thyroid binding globulin is very high, which can occur when the estrogen levels are too high, this can bind to more thyroid hormone. And this can kind of just create this issue where we're not having enough hormones produced that we need. So estrogen dominance can increase sex hormone binding globulin, which will bind to all hormones, including testosterone. So sex hormone binding globulin is a glycoprotein that binds to 3 different types of hormones, 2 different types of testosterone, as well as estrogen. So if we see increased SHBG, then this will start to kind of promote the body to produce more hormones to attach to those empty receptor sites. So I'll get into that one a little bit more here. The next one that we're going to talk about is progesterone. This is formed by cholesterol and made within the corpus luteum. The corpus luteum, if you don't remember, that's the part of the follicle that is left after the egg has been released from the ovary. The corpus luteum is what produces the progesterone, and then it eventually kind of just disintegrates. So progesterone is often referred to as the pregnancy hormone, and that's because this is a hormone that's very dominant during pregnancy. It really helps to support the uterine lining and really helps to support the growth of the baby as well as the placenta. So there's a lot of really good things that we get from progesterone. I'm going to make a note right now. One thing that we do see in hormonal birth control is something called progestin. And this is not the same as progesterone. These are different. So the body does not recognize progestins the same way that it recognizes progesterone, which means it makes it difficult for the body to process this. Progestins can bind to many different receptor sites, including that sex hormone binding globulin. So this can kind of throw the body off when it's trying to determine what the actual hormone levels are at. Progesterone is also neuroprotective, and I know that this doesn't really relate to what I'm talking about tonight, but I did think that this was very interesting. They had a couple of studies where they looked at rats that had TBIs or traumatic brain injuries, or what you may know as concussions. And they found that giving these rats progesterone increases their neural regeneration quicker. So it's pretty cool to see that progesterone can actually help to support the brain as well. All right, so back to sex hormone binding globulin. This is primarily produced in the liver. And again, like I said, it binds to 3 different types of hormones, dihydroxytestosterone or DHT. It binds to testosterone as well as estradiol. So what sex hormone binding globulin does is it controls the amount of testosterone that the body tissues can use. If we start to see low sex hormone binding globulin, this means that there's more hormones available to use. This is what we'll see typically in women that have PCOS. If there's high levels of sex hormone binding globulin, that typically means that there's less hormones available to the body. So how this can relate to women that have PCOS is if we're seeing that low sex hormone binding globulin, and there's more hormones available to use, this could mean that if there's excess testosterone in the body, that there's a lot of testosterone floating around, which is one of the key features of PCOS. So that's kind of what this protein is that we're looking at here. The next one is follicle stimulating hormone. So I kind of touched on that a little bit already, but I'm going to kind of go over this again. So FSH is released from the anterior pituitary gland. FSH then stimulates the ovarian follicle, which allows the egg to grow. And that eventually triggers the production of estrogen in the follicle. So if we're looking at this picture here, we can see FSH coming down from that arrow. It's talking to the ovarian follicle. So those little yellow cells that are kind of making the actual circle, those are the follicle cells. And the oocyte, that blue circle that we see in the center, that is the actual follicle being developed. So this is kind of what's happening during this process of FSH being released in the body. Luteinizing hormone is also produced in the pituitary gland, and the rise in luteinizing hormone is what causes the egg to be released from the ovary, or what we would call ovulation. In the now empty follicle, the cells proliferate, and this is when it turns into the corpus luteum. So if we look to this picture on the right, we can start to see, if you look at what would be 12 o'clock on a clock, we look at the primordial follicles, that's the beginning of the follicles developing. If you follow the ovary around counterclockwise, you can start to see that follicle get larger and larger. And eventually we see the egg being released, and we see the corpus luteum. And as we kind of continue to follow that around the ovary, we see it start to disintegrate, and this is how the cycle begins again. So the corpus luteum releases the progesterone and a little bit of estrogen. And what this does is it helps to inhibit the further release of gonadotropin releasing hormone, or something called GnRH, and thus the secretion of LH and FSH. So basically, by the corpus luteum secreting this amount of progesterone, it's kind of telling the brain, hey, we don't need any more FSH and LH. And then that's why we see that drop in FSH and LH at that time. Gonadotropin releasing hormone, so I just mentioned that one previously, just to give you a little idea of what this one is it's a hormone produced in the hypothalamus that is responsible for the release of FSH and LH. So we can see that GnRH up at the top of the hypothalamus in the picture to the right. Another hormone that we'll be talking about is DHEA. So this is considered the most abundant steroid hormone in the body, and this one is also made from cholesterol. So if you look at the picture to the left, we can see cholesterol in the top left corner. And if you kind of follow that flow chart all the way across throughout the different arrows, you can see where all of our hormones come from. So cholesterol is definitely at the top of all of that. So DHEA is what can eventually help to form androstenedione, which is considered one of our androgens, as well as testosterone. And if you see in that picture there, testosterone is actually what helps to get converted into estradiol. So that's kind of interesting what we're looking at here. And lastly, testosterone. This is a steroid mostly found in males, but it's also present in females and is also made from cholesterol. So testosterone can be cardioprotective, a mood stabilizer. It can help us preserve our sexual function or even our libido. And a little fact for the men, it can help protect against prostatic hyperplasia or increased growth of the prostate. So after I've reviewed all these hormones, the next question is, what is the cause of all of this dysfunction that we see in PCOS? Well, I don't think there's really one answer specifically. I think it's a number of things that can contribute to this disorder overall. So the first thing may be poor food choices. If we're eating poor food choices, which contain a lot of sugar, this could eventually lead to insulin resistance, which could eventually lead to disruption of hormones. We may also see issues stemming from ubiquitous use of birth control during maturing ages, excessive stress and stressors, which applies to a lot of people these days, different endocrine disruptors, and medications, just to name a few. All right, so PCOS. Now we're kind of jumping in here. I gave you guys a little bit of the physiology lesson and endocrinology lesson, and now we're here to talk about the disorder. So what we see in PCOS is disruption of androgens. We typically see excess androgens and ovulatory issues. We see obesity in 30 to 75% of these patients, and insulin resistance is present in a lot of these patients as well. So I really like this picture because I think it can give you a good look at what's happening in the ovaries during PCOS. If we look at the picture on the left, we see that enlarged follicle. Now, that's the follicle that grows throughout the month, and then eventually what becomes the egg. However, if we look to the other side, we see a lot of these cysts forming. And if you kind of remember what I was talking about earlier with the folliculogenesis, is in PCOS, we're not having that signal from the brain telling those follicles to quit developing, and so they continue to grow and grow and grow, and then that's when they become cystic. So some symptoms of PCOS include weight gain, fatigue, unwanted hair growth, hair loss, acne, pelvic pains, sleep problems, infertility, and this list could be a lot longer. These are just some of the more common ones that we see. So what causes this to happen? Again, this could be a very, very long list of different things that we could talk about. I'm trying to kind of focus on the main ones tonight. So first of all, gut infection. High stress and gut inflammation can upregulate what's called the HPA axis. So the HPA stands for hypothalamic pituitary adrenal axis, which means areas of our brain are talking to our adrenal glands, and this is kind of what control our stress response. So if it's upregulating the HPA axis, this can lead to increased cortisol. Increased cortisol can then lead to weight gain and irregular menstrual cycles and elevated androgens as well. Another thing that can cause this dysfunction to happen is thyroid dysfunction. I'm going to get into that a little bit more. We may see, of course, some estrogen and progesterone irregularities, insulin resistance, elevated androgens, and adrenal insufficiency. So they may be producing too much cortisol. So if we look up here at insulin resistance can eventually lead to too much production of insulin, which can lead to hyperinsulinemia. What that can do is decrease the amount of sex hormone binding globulins in the body. And we kind of talked about that already. If that becomes lower, then that means that the amount of free testosterone in the body can increase, which we see here as well. If we have too much testosterone, that eventually can lead to anovulation or not ovulating. And if we're not ovulating or releasing that egg, then the ovary isn't able to produce that progesterone like it should be. And looks like I apologize, we're having some connection issues right now. Okay, I think we're back. So when we do see the increased insulin as well, this can start to lead to cells called the theca cells in the ovary to enlarge. This can also lead to anovulation and decreased progesterone production. So thyroid dysfunction and PCOS. Research has shown that thyroid disorders are more common in women with PCOS. Even specifically, we're seeing a lot of Hashimoto's, which is the autoimmune form of hypothyroidism. We're seeing a lot of Hashimoto's show up in women with PCOS. And the connection between these two disorders is kind of hard to distinguish if we're looking at a thyroid issue or if we're looking at the sex hormone issue. So it's really important to consider both of these when we're talking about discussing or diagnosing PCOS. So rise in a hormone called thyrotropin releasing hormone, or TRH, in primary hypothyroidism, or low function of the thyroid, can lead to increased production of something called prolactin and increased production of a hormone called thyroid stimulating hormone. What these two things can eventually do is increased prolactin levels can inhibit ovulation from occurring due to the disruption of FSH and LH that it has. So we kind of talked about how those are important previously for ovulation. So if we have too much prolactin, it can really disrupt this ratio. And we see this in both Hashimoto's and PCOS, which is pretty interesting. So this is kind of some things that can happen with the thyroid. Symptoms of low thyroid function include fatigue, weight gain, or difficulty losing weight, coarse or dry hair, dry skin, hair loss, cold intolerance. So there's a lot of different symptoms here that you can see that present with hypothyroidism. What's interesting with this is these are a lot of the same symptoms that we see in women that have PCOS. So the line trying to diagnose or differentiate the two from each other can become somewhat blurry when we're only looking at symptomatology. This is looking at a hormone test. So I know this may be a little bit overwhelming as we're looking at it here, and I'll kind of jump into it a little bit more as we move on. But what this is looking at, and this is a test that I like to run that looks at both the hormones and their metabolites. So if we look at the picture on the left here, where that blue arrow is pointing, those are showing us elevated androgens. As we can see, that reference range should be between those two stars. And this patient is very far out of the reference range. That red arrow is kind of showing them being out of it. Also, if we look over here to the right, we see increased estrogen. And this may be pointing to estrogen dominance. If we follow this pathway kind of through this picture, you can see that there's red arrows on almost every reference range on this page. So this patient is producing a significant amount of hormones. And I'm just going to kind of keep going through and showing you these different things. So it's okay if it seems kind of overwhelming. I'm going to try and explain it a little bit more as we continue moving forward. So another thing that we consider with PCOS is stress. And stress is something that we see in all types of patients, and all of us have experienced it at some point. However, too much stress can actually lead to adrenal insufficiency, or your adrenal glands unable to function as well as they should. In this particular patient, we can see that their cortisol levels are super high in the morning. So what happens with cortisol is we should see an increase in cortisol upon waking. This is what helps us to wake up in the morning. This is what helps give us energy throughout the day. If we're looking at this picture here, you can see where the high range and the low ranges are. You should ideally fall in between those two. So in the morning, you can see that there's that steady rise of cortisol throughout the day. And then after the morning, it kind of starts to drop and drop and drop, and it gets to its lowest at nighttime. This is so that we can fall asleep and begin our cycle again the next day. Cortisol also kind of fits with our circadian rhythm, or our sleep and wake cycle. So we see cortisol kind of fluctuate with those different melatonin levels as well as our sleep-wake cycle. So what happens during a stress response, and this is something I really like to explain to patients because I think that this plays such a major role in so many different disorders that we're faced with, even outside of PCOS. So what happens during a stress response is the brain has this environmental stressor that comes to it. So this could be something as simple as driving on the highway behind someone that's really slow, or being in a lot of traffic. Another stressor could be being really stressed at work. Maybe you're dealing with a very difficult task, or something that's requiring a lot of energy or a lot of focus. It's very stressful to you. Maybe you had a family member die, or a significant other, issues with your significant other. So stress can come to us from all different avenues. It doesn't necessarily have to be just sitting there, taking a test, being stressed. So the problem with this is our bodies are not able to process the stress as well as we should be. So thousands and thousands of years ago, as humans, if we were faced with something stressful, it was typically, are you going to die, or are you going to run for your life? And in that moment, our brain had to decide what it was going to do. So I'll kind of explain how this works as I go through this process. So the first thing that's activated in the brain is something called the hypothalamus. And you've heard me talk about this already, because this is what I talked about, the HPA, or the hypothalamic pituitary adrenal axis. What happens then is the hypothalamus sends a signal to the pituitary gland. The pituitary gland then sends a signal to the adrenal glands, and the adrenal glands produce cortisol. The increased cortisol that's released from the adrenal glands sends a signal to the liver to release glucose. The reason it does this is so that our body can use that glucose to run. So kind of to go back to what I was talking about thousands of years ago, if you all of a sudden came across a bear and you're like, oh my gosh, I have to fight this bear, I have to run for my life, your brain is telling you, okay, I'm preparing you for this. So it releases glucose to help our body have a lot of energy. So glucose is the primary source of energy that our body prefers. Our body prefers glucose over everything else. The problem is if we're not in a situation where we're going to be burning up this glucose, then we just end up having excess glucose released in the body. How we can relate this to insulin resistance is if there's constantly too much glucose being released, then this is putting a big strain on the pancreas to release too much insulin. And this is kind of where we can start to see this pattern of insulin resistance forming. Another really interesting thing to keep in mind during this time of stress is the immune system is suppressed during this time, which means your body is more likely to become sick. You're more likely to injure yourself. You're more likely to stay sick. So a lot of different things that can also occur just from the stress response happening. Insulin and PCOS. So insulin is a gonadotropic hormone that works with luteinizing hormone in the regulation of ovarian steroidogenesis. So insulin and that LH kind of work together to help the ovary produce different steroids. Insulin can also amplify ovarian androgen production rates, which means if we're having excess amounts of insulin in the body, then it's telling the ovary to produce more androgens, which is just, we're starting to kind of fall into this vicious cycle of too much insulin, too much testosterone, and it just keeps building and building and building. Insulin can also reduce the major carrier protein of androgens, sex hormone binding globulin, which can eventually increase that amount of free testosterone available again. So this is why it's important to kind of consider all of these different factors when we're looking at PCOS. Just to kind of explain a little bit further with this, it's estimated that 65 to 70% of women that have PCOS have insulin resistance. 70 to 80% of these women are considered obese, and an additional 20 to 25% of these women are considered lean. So insulin resistance doesn't necessarily occur only in people that are overweight. This can occur in people that are also considered lean. So this is important to remember as well. The increased insulin levels can cause the ovaries to produce more androgen hormones. And again, it can also decrease the amount of sex hormone binding globulin, which makes the body kind of produce more free testosterone. So it's a little bit of a double whammy there. So kind of what we're looking at here of test to run would be something called HbA1c. This is a gold standard for diagnosing diabetes. Of course, we would want to look at fasting insulin as well as fasting glucose. If we're looking at this picture to the right to kind of give you an idea of what's happening in insulin resistance. So the purpose of insulin is to reduce glucose levels. So typically what happens in an insulin response is, let's say you eat something, let's say you just have a sandwich. Your body takes in all this glucose, and then all of a sudden it says to the pancreas, hey, we got to bring these glucose levels down, and the pancreas releases insulin. The insulin then helps to push the glucose into the cells, and then the cells get released or digested by the body. With insulin resistance, the body is producing so much glucose, or there's so much glucose being taken in by the body that the amount of insulin being produced can't keep up with it. So the glucose is no longer responding to the insulin and becomes insulin resistance. So we're no longer seeing those glucose move into the cells, and this is when we'll start to see those increased blood values of glucose in the body. Obesity and PCOS. So androgens can be stored in adipose tissue. Adipose tissue is considered fat tissue. And in this fat tissue, concentrations of these androgens may actually be higher than blood levels. So if we're drawing blood levels to see what the androgens look like, and there's a lot of adipose on a specific person, the values that we're seeing in the blood may actually be lower than what it is in the entire body. So androgens have the ability to also convert pre-adipocytes into adipocytes, meaning androgens or things like testosterone can convert fat cells or pre-fat cells into fat cells. and specifically visceral fat. And this is the bad, dangerous fat. This is the fat that can surround the organs and can eventually lead to a lot of other issues in the body. So what we're kind of saying here is weight loss is crucial in these patients because we want to make sure that their body isn't storing excess androgens. We want to make sure that they're getting rid of it as efficiently as they possibly can. So what tests should be considered based on kind of what I've covered so far? Fasting glucose and fasting insulin, HbA1c, 2-hour glucose tolerance test, thyroid panel with antibodies and reverse T3, prolactin, FSH and LH, consider pelvic ultrasound to look to see if there's actually cysts on the ovaries, and hormone testing. So the Dutch test is just a test that I like to use. It's an acronym for dried urine test for comprehensive hormones. That's the picture that you've seen on some of the previous slides. I also like to use a hormone testing company called Rhine Laboratories. So that's who I do a lot of my hormone testing through. So different treatments that I may consider for these patients, it's going to vary because, like I said, not every patient that has PCOS is going to have insulin resistance. Not every patient is going to have a thyroid issue, but some patients may have both. But I don't want to treat insulin resistance in someone that doesn't have insulin resistance. So some of my treatments are going to vary person by person, and this is why when I have this, what's a quick fix for my PCOS? I don't really have that good of an answer. So these are some of the more common things that I'll use, some very basic things. Natural hormones. So women often ask me what makes them natural versus the birth control pill. And what I like to use is hormones that come from plants. And the reason that I like these is our body is able to process and recognize these very easily. The reason being is our bodies have been consuming plants for thousands of years. We know how to process plants in our bodies properly. So by getting the hormones from these plants, the body's able to recognize and process them very efficiently. And inositol is a product that helps to regulate blood sugar levels. This can also help to decrease anxiety at times. B vitamins, I prescribe to a lot of my patients, especially with those that have been on birth control. Birth control can deplete you of a lot of different vitamins. B vitamins being the number one, can also deplete you of zinc, also can deplete you of something called selenium. Selenium is really important for the conversion of the thyroid hormones. So if we're seeing deficiencies in selenium, then this may also be where we start to see some of these thyroid issues. Omegas are really important. They're very anti-inflammatory to the body. They also help to provide the good types of fat that our body needs to help build those different hormones. Curcumin is another really strong anti-inflammatory, and this condition is a very inflammatory condition. So we really like to work at reducing inflammation in the body. Thyroid support if necessary or if indicated. Probiotics, and I get a little specific with the types of probiotics I use based off of what the patient's complaints may be. I do see a lot of digestive disorders with PCOS and with hormone complaints in general. So sometimes my first area of treatment is actually treating the gut before I will treat your hormones. Sometimes I'll use adaptogens. These help to support the adrenal glands and help them to function optimally. I pretty much with every patient make dietary changes. Sometimes we'll do different food tests to see what the patient may be sensitive to. Sometimes we'll do an elimination diet. It's, again, all kind of depends on the patient. Vitamin D is something that I prescribe in a lot of people because a lot of people are deficient in vitamin D. Vitamin D is really crucial to supporting the immune system, so that's something that I always like to consider. And then antimicrobials may be used for fighting off any type of gut infection. So this is kind of a short list of some of the most common things that I use, but not including everything. So I actually have a case study to present to you guys now. And this patient came to me in March of this year. She's 26 years old, 66 inches tall, and 120 pounds. When she first came to me, her major complaint was digestive issues. She was puking every morning and it would come and go. So she would have weeks where she would wake up and puke. And then she would have times where she was fine. She was having a lot of diarrhea. That would also kind of come and go. She'd have weeks of diarrhea and then wouldn't have any issues. She did have constant heartburn and was taking some medications for that. And she told me that was her primary complaint. One of her other complaints was that she hadn't had a period in over 9 months since coming off of her birth control, and she had been on birth control for 10 years. She also had noticed some increased facial hair, and she said that her acne got a lot worse when she came off of the birth control. She reported low libido, and she did have some blood work that she came in with. One of the more notable things was her CRP. This is a marker for inflammation in the body. I don't like to see it above 0.5, and she was at 15. So this is just kind of an overview of this patient when she first came in. So what I started her on for treatment was emulsified oregano. This was to help with her gut infection that she had. I gave her some high-dose curcumin based off of those high levels of inflammation in her body. I gave her a probiotic called S. boulardii. This is a beneficial yeast, so it helps to support the gut lining as well as kind of crowd out the bad yeast in the body. I gave her some B vitamins because she was B vitamin deficient, and some L-glutamine to help support the gut lining. Another big thing that we did at this time was change her diet pretty significantly. So I had her starting to cut dairy, sugar, gluten, soy, as well as alcohol. And she started to decrease her amount of carbohydrates she was eating and instead started to increase her fats, proteins, and vegetables. So this was about a month later, 4/20/2018. The patient said that she hasn't had any puking or diarrhea since starting treatment. She says the bowels have improved, they're more formed, and she's no longer having any diarrhea. She says acne has cleared up pretty significantly. Cramping and period-like symptoms have started to show up, and she started to notice some vaginal discharge that she hasn't had in over a year. So this was all with just treating the gut and making some dietary changes. We hadn't even started to look at her sex hormones yet. So at this time, we dropped the antimicrobial for the gut and also the L-glutamine, and we did some hormone testing and additional lab work at this time. So this is what her labs looked like when they came back. If we look at this top left corner, this blue arrow, this is showing high levels of testosterone. So we can see if you look kind of in that top white box, this testosterone, the range should be anywhere from, for someone her age, it should be between 4 and 14, and she's at 20. So her testosterone was very, very high. What we look at, and what's nice about looking at these metabolites or these different forms of these hormones, is we can see that she shows a preference for something called 5-alpha metabolism. What this means is the way that her body is breaking down androstenedione is preferring this different type of metabolism. And this 5-alpha pathway can actually exacerbate symptoms from elevated androgens. So not only are you having these high androgen or high testosterone-like symptoms, but now your body is kind of metabolizing them in a way that it makes them worse. So one of our goals was to try and switch her to a pathway that favored the beta pathway, or the lesser androgen-like pathway. If we looked at some of her other sex hormones to the right, we can see progesterone and estrogen, and both of these hormones are pretty much tanked. So she should be falling in between those two yellow stars. You can see that her arrows are pointing at the purple boxes, which is where a menopausal woman's hormones should fall. So she had a lot of testosterone and not very much progesterone or estrogen. So this was kind of a big finding for us. We also ran CRP and some additional blood chemistries. So we saw that her CRP was now at a 0.58, so that had dropped 15 points. A lot of this was likely due to the strong anti-inflammatories she was taking, as well as her dietary changes. We found that there was no insulin resistance or evidence of diabetes present. She had never had that ran prior to being diagnosed with PCOS. We found that she had a low functioning thyroid, she had elevated testosterone, and low progesterone and estrogens. So some of the treatment that we started that day was thyroid support. I gave her something to help support the pituitary and hypothalamus connection, or that HPA axis. I gave her something called Palmetto Plus to help her switch from that 5-alpha metabolism to the 5-beta metabolism. I gave her estrogen and progesterone drops to help increase those hormones in her body. I gave her a multi-strain probiotic and B vitamins, and she is supposed to start tracking her period-like symptoms. or even ovulatory-like symptoms that she may be having. So we didn't follow up again until 8/11. The patient had a lot of things going on during that time. She got married, so there was a lot of things going on. Our appointment was a little bit later than usual, but she did say that her sleep has improved. She says that she did have a little bit of diarrhea, and she thinks that it may have been related to her cheating on her diet a little bit more. She says that she's now starting to experience some depression, and she's noting consistencies, but she is noting consistencies in timing of her discharge and her symptoms. So she's starting to notice that she's having discharge consistently on the same day of every month. And she's also noticing some cramping and different types of PMS-like symptoms as well, leading at some of those times of the month. And she's also gained some weight. So one of her goals was to gain weight because she's always been on the thinner side. So she was happy that she's gained some weight. And at that time, the only changes that I made in her prescription was to increase her dosage of progesterone and estrogen. She ended up going and having an ultrasound done because she had a lump show up in her stomach. And she found she didn't have it. They didn't know what the lump was from, but they did see on her ovaries that she had large follicles. There were no cysts present. They saw that her uterine lining was very thin at 1 millimeter. At that time, the nurse practitioner told her if she didn't take birth control and metformin, she wouldn't be able to have kids. So that was somewhat of a traumatic appointment for her. She did decline the prescriptions at that time. And after we had talked, I added ashwagandha, which is an adaptogen, and also some vitamin D. And we did find out what was causing some of her belly issues later on, including that lump and the diarrhea. And she reported that she had removed eggs after that visit and that the abdominal discomfort had went away. So did the lump. So she related a lot of the gastrointestinal issues that had shown back up to the eggs. She also said after she removed the eggs, she noticed that she didn't have any more depression either. And once she had cleaned her diet back up. So she did notice some blood on the 15th of August. She said that she noticed, and this was her tracking all of her symptoms like I had asked her to. She said that she had noticed cramps, acne, and fatigue on the 4th of September. She noticed a little bit of discharge on the 15th, and she had some bright red blood at the end of September. She said that her moods had been great. She wasn't having any more depression, and she says that her acne has significantly improved. So our most recent visit with each other was November 9th. She says that she's noticing a creamy discharge during the month now. She also had bleeding from the October 24th through the 26th. She said this was the most blood that she's had yet, and she was very surprised because she wasn't ready to have that much blood, but she was pleasantly surprised. She thinks that she's noticing a spike in her temperature, and she believes it's at ovulation because she's noticing it at the same time that she's having some of her other symptoms. She says that, again, the abdominal pain has subsided since removing the eggs, and she says that her sleep has improved significantly. So I haven't seen this patient yet since this was just a month ago, but she has continued to improve pretty significantly. So she's seeing blood now once a month that she wasn't seeing before. And she's feeling great overall. Her energy's improved. She's no longer having any gastrointestinal complaints that she was previously having. So this patient is doing quite well. So I just wanted to present to you one of the types of cases that I may see in practice. And it's interesting, and people sometimes get confused when they come in to see me. They're like, I'm coming to you for my hormone issues. Why are you talking to me about my gut health? And this is why, because healing the gut and helping the gut to heal helps the body to improve overall. So that's why sometimes you may not be treated for the specific thing that you think you need, but it may be indirectly helping that major complaint that you may be having. So I just want to thank you for joining me tonight for my webinar. And if you have any questions, feel free to contact me at my office. This is my phone number. I am on Instagram. I'm pretty active on there. Facebook is this is my office Facebook page that I'm a part of. And I will be sending these notes out to you, so you will have my email address. So if anyone has any questions at this time, I would be really happy to answer any of those for you. All right, so one of my questions is what types of thyroid tests should I ask my doctor to run? So traditional medicine doesn't always look at the same types of thyroid tests that functional medicine doctors look at. The ones that I like to recommend to patients would be looking at something called TSH, something called free T4, free T3, reverse T3, anti-TPO, and thyroglobulin antibody. And what those last two are is they look for autoimmunity to the thyroid. So these will be your tests that look for that Hashimoto's. The reason it's important to look at all of those different types of thyroid hormones is because looking at TSH all on its own really doesn't give us a great idea of how the thyroid's functioning. So it's really important to look at all of the hormones that the thyroid produces to see how well they're being processed. So to answer that question, another question, one of the most common questions I get from people is what should I do to help my condition? So a really easy place to start that you can do on your own is remove foods from your diet and clean your diet up. So cut all processed foods that needs to all be cut from your diet. If you're not able or capable of doing a food test, then I would suggest starting by eliminating the top 5 culprits that I see in practice, or the top 5 sensitivities I see in practice. That could be gluten, dairy, peanuts, soy, and eggs. And I really don't like any of my patients having soy because it has a lot of estrogen-like properties to it. So if we're dealing with hormone issues here, continuing to eat something that may affect your hormone levels is something that we should just completely remove. So that's one of the first places that you can start on your own, is to just clean your diet up. Eat a lot more veggies, eat a lot more protein, cut the carbohydrates, really decrease the amount of carbohydrates you're having because that will increase the amount of glucose in your body. So yes, just really, really clean up your diet. All right, and the last question, if I'm not getting my period, does this mean I have PCOS? So not necessarily. Just like we looked at that criteria way at the beginning of the PowerPoint, just because you're not getting your period doesn't necessarily mean that you have PCOS. There are a lot of other things that could be happening in your body that could be causing this to happen. It could be something like your thyroid not functioning very well, and treatment of your thyroid might help regulate your period. Yes, it may be PCOS. It could also just be your body not producing the amount of hormones that it needs. So there's a whole list of things that could be causing your body to not have a period, but it doesn't necessarily mean that you have PCOS. So thank you all again for joining me tonight. I will be sure to get this PowerPoint out to you as soon as possible, as well as the recording if you want to kind of join in on another date. I know that there were some connection issues, so I'll make sure that that's fixed when I send this out. So I hope you all have a great night. And again, thank you for joining me.